Hello, and welcome to the Texas Rec Educational Series. This session is being recorded and will be posted on the texasrecs.org webinars page if you want to review the content or share the information with your friends and colleagues. Our speaker today, Deb Norris, will be speaking about Medicaid EHR Incentive Program, Stage 2, Meaningful Use. All attendees have been muted to block out background noise. If you have questions for our speaker, please post them in the chat block of the GoToWebinar pane. Your questions will be read to the presenter at the end of the presentation. If we are unable to answer your question during the allotted time, you will receive an answer via email. First, some information about our speaker. Deb Norris has a diverse background in public policy, science, and technology. She has worked in the private sector as a consultant and in the public sector as a policy advisor at HHSC. She currently works with the Health IT Division of the Texas Health and Human Services Commission, HHSC, and is a project manager for the Medicaid EHR Incentive Program. Deb has published papers in peer-reviewed journals as well as author articles and reports for state and national organizations. She holds a degree in biology from Michigan State University and a master's degree from the University of Texas LBJ School of Public Affairs. Thank you for joining us, and I will now turn over the webinar to Deb Norris. Deb, the presentation is yours.
Thank you. Good afternoon, everybody. Hopefully you can hear me, and hopefully you can see.
Yes, we can see your screen.
Okay, great. Well, I'm going to do just kind of a brief overview of Stage 2 and talk about just some high-level things that have happened with the transition to Stage 2 and the program in general. And then I'm going to do a walkthrough of some screenshots from the MI360 attestation portal for Stage 2 to give you all a sense of what that looks like. It's the same layout as you have seen for AIU and Stage 1, but I thought it might be interesting to go through and talk about some of the individual meaningful use measures and be able to see it as it actually will look in the portal. So just quickly, a reminder for everyone on what the attestation timeline is in the Medicaid EHR Incentive Program. And so even with Stage 2, the program layout is still the same. All eligible professionals will do their adopt, implement, or upgrade in their first year. And then everybody does 2 years of Stage 1 meaningful use. And that's where you meet all of the measures for Stage 1. And then you'll do 2 years of Stage 2 meaningful use. And Stage 2 just implemented this year in 2014. Very similar to Stage 1, but some of the measures have changed. Some of them have higher thresholds, but the concept and the theory is the same. And then once CMS finalizes the Stage 3 meaningful use rule, the final year, for people who are in their final year of the incentive program, they'll do Stage 3 meaningful use. And just a reminder to folks that the last year to start participating in the program is 2016. So for any eligible professionals out there who haven't started the program yet, you want to make sure that you at least do your first year by 2016. So what's new in 2014? Well, one of the big things is that everybody, regardless of what stage of meaningful use you're in, will have to upgrade to a 2014 certified EHR. So you'll want to make sure that you talk to your vendor, make sure you have the 2014 certified version of your EHR. And then for 2014 only, everyone will attest to a 90-day meaningful use reporting period, regardless of what stage you're in. So in normal instances, your first year meaningful use, you would do a 90-day reporting period, and then your second year you would do a 365-day or full year reporting period. But CMS in the Stage 2 rule announced that for 2014, everybody, regardless of where you are in the program, will get to do just a 90-day reporting period. Some things that are new in Stage 2, there's a focus now, a greater focus on health information exchange and advanced clinical processes. The measures are similar, but there's higher thresholds for some of them. There are a couple of new measures, and some measures have moved from menu to core. but as I said, the concepts are generally the same. There's an emphasis on electronic transmission of patient care summaries across multiple settings. We'll see that in some of the measures. There's a focus on increased patient and family engagement, and you'll see that in some of the measures where there's actually a requirement that the patients participate in an electronic transmission with their providers. And then starting in 2014, the clinical quality measures, or CQMs, will be the same for all stages of meaningful use. Just a quick little comparison of stage 1 versus stage 2. You'll see that for stage 1 there were 13 core measures. Now in stage 2 there's 17. For the menu, in stage 1 there were 5 out of 10 that you could choose. In stage 2 you'll choose 3 out of 6 menu measures. So you'll have 18 total measures in stage 1, and there's 20 total measures in stage 2. For the CQMs in stage 1, you had to choose 6 out of 48, and for stage 2 you'll choose 9 out of 64, and they have to come from at least 3 of the domains identified by CMS. Another new thing in stage 2 is that your exclusions can really only count. You have to choose menu measures that you can meet before you take any exclusions. So in stage 1, you could pick measures and just take the exclusions. In stage 2, if there's any of those measures you can meet, you have to respond and attest to those measures first before you can move on to any where you might be able to take the exclusion. One thing I did want to point out is some of the documentation that you'll need for your meaningful use attestation. We are requiring a certain level of documentation to be uploaded at the time that you attest. This will help you in terms of your record keeping for post-pay audit, and it helps us in terms of verifying your eligibility. It's still important to keep records for everything that you do and everything that's part of your attestation. So we really want to emphasize taking screenshots, reporting, keeping copies of your meaningful use report, things like that. So, as I said, a lot of this stuff is going to be required of you at the time of attestation now, and then you can upload it. It will be there, and then we recommend that you keep copies on your own. We'll be asking you for a meaningful use summary report or comparable information that's generated directly from your EHR, and that'll help you fill in your meaningful use measures. Screenshots for yes/no measures, things like that, would be very helpful for us and for you to have. For CQMs, we're not requiring any documentation during attestation, but we encourage you to keep documentation of that. All of these things can be audited in post-payment audit. So even if we don't ask for something during your prepayment review, that doesn't mean that we can't or wouldn't ask for that in a post-payment audit. So that's why you really want to keep really good records of all of your attestation details. There's an article on TMHP that talks about the different meaningful use measures and documentation that's required. And again, just really want to emphasize to keep good records and retain everything for at least 6 years in case of audit. I would say my recommendation would be if you have any doubt about whether you should keep something, go ahead and keep it. If you have any doubt about how you're going to document a particular meaningful use measure, take a screenshot from your EHR at that time, something that shows your name, shows the date, shows what it is that you're capturing, and that will be helpful for you. So with that, I'd like to get into some screenshots of the actual portal. I'm hoping that that text is big enough for everyone to see. So this should look familiar to everyone who's done any attestation. It's the same layout for stage 2. This is a screenshot for someone who, we're skipping the initial stages where you'll log in and you'll verify your provider registration data, and you'll do your Medicaid volume attestation. So that part of this is pretty much the same. So I've skipped that and just gone straight to the page that you'll get to when it's time to attest for your meaningful use measures. So from here, you'll, as you did for stage 1, you can do your core measures, your menu measures, and your CQM. So you click on the one that you wanted to do. So here, So this is what, once you click on Attest to your core measures, it brings up just this short little summary. You've seen this in stage 1. And then you'll get to your core measures. And so first measure for stage 2, like stage 1, is use of computerized provider order entry, or CPOE. What's changed for stage 2 is that the threshold has gone up for medication orders from 30% to 50%. And it also has, this measure now has 3 parts. So in stage 1, you just attested to your CPOE for medication orders. Now you'll attest for medication, lab, and radiology. There's an opportunity for an exclusion, which is similar to the exclusion right here for stage 1. So in the portal, when you attest, you'll get this in several parts. You'll get the first part, which is where you'll attest to your medication orders. You'll get part, and you'll get a chance here to select whether the exclusion applies to you. You'll get a chance to fill in your numerator and denominator for your measure. And then you'll get to the second part. So this, you're still in that very first measure, but the second part is now you'll enter your laboratory orders, and you've got to have at least 30% of your laboratory orders created by CPOE. Same thing, you'll get a chance to answer the exclusion question here, enter your numerator and denominator, and then you'll get to part C, and this is where CPOE for radiology, and the threshold there is 30%. That'll take you to core measure 2, and this is your e-prescribing measure. The change here in stage 2 is that your threshold has increased from 40% in stage 1 to 50% of your prescriptions transmitted using e-prescribing, and you also have to compare it to at least one drug formulary. So you'll get a chance to answer the exclusion question. You'll fill in your numerator and denominator here, and then we ask you to name the e-prescribing services and at least one pharmacy that you transmit to. The third measure is reporting of demographics. This measure is pretty much the same as stage 1, except for now, instead of reporting 50% of your patients' demographics, you have to do 80%. For our measure 4 is reporting vital signs. There were some age-specific changes in stage 2 where CMS was a little bit more clear about which particular vital signs apply to certain age groups. And then the threshold also increased from 50%, reporting 50% of your patient's data to 80%. So again, there's an exclusion here. The actual vital signs that you would record and chart are the same as in stage 1. Core measure 5 is reporting of smoking status for patients age 13 and older. This measure is the same as stage 1, except it's increased from 50% to 80%. So what you're seeing here is this trend in stage 2 of trying to get providers to have more and more of their patients' data reported in the EHR. For measure 6, this is using clinical decision support. This now has 2 parts. So it used to be just a 1-part measure. It also, in stage 1, the measure just asks that you implement at least 1 clinical decision support rule. In stage 2, you've got to implement 5 rules. And the other change is that this measure also now includes the drug, and drug allergy check. That was its own unique measure in stage 1. Well, that's now been rolled into this measure for stage 2. So you'll see here, so this has several parts to it. You'll be asked to list 5 different clinical decision support rules here instead of 1. And then on the second part, it asks about whether you have implemented your drug-drug and drug allergy interaction checks. So again, this was its own measure in stage 1, and now it's just rolled into this measure for stage 2. For measure 7, this is patient access to their health information. And this is the ability to view, download, and transmit patient health information. So previously, you were allowed to provide this information to your patient in pretty much any format within 3 days. For stage 2, this has 2 parts now. It requires online access, and there's some patient engagement required in that more than 5% of your patients have to view, download, or transmit their information to a third party. So here in the measure, we'll list the various types of information that could be included in the transmission, and the types that need to be made available online. There's been a chance to test for an exclusion to this measure. So the first part is how many patients you are allowed to view, download, or transmit their information within 3 days. The second part now here is the patient engagement part, and this is where more than 5% of all the patients seen by the provider have to view, download, or transmit their information to a third party. So this requires some interaction between provider and patient, as opposed to just the provider doing something. For measure 8, this is providing clinical summaries to patients for their office visits. This measure is very similar to what you saw in stage 1, except in stage 1 you had 3 business days to provide these clinical summaries to your patients, and in stage 2 you have one business day to do that. For measure 9 is protecting health information and using secure capabilities. This is the measure that you saw in stage 1 as well, and this requires that you conduct a security and risk analysis of your EHR system, and that you correct any identified deficiencies. This is one that we really want to encourage providers to document. This has to be done annually for your attestation, and so you want to make sure that you've documented that you've done this analysis and that you've addressed any deficiencies that you found. We are asking also at the time of attestation that you upload some documentation of that security risk analysis. Measure 10 is incorporating lab test results as structured data into your EHR. Very similar to the stage 1 measure, but the threshold is increased. So in stage 1, you have to do 40% of your lab. For stage 2, you do 55% incorporated as structured data into your EHR. And you'll see here, you'll put in your attested exclusion or not. You'll do your numerator and denominator. And then we also ask what was the lab test results entry method. How did you actually get those lab test results into your EHR? For measure 11, this is generating patient lists. I apologize, I'm realizing some of these have smaller print than the other. I hope you all can see them. There's no changes in this measure between stage 1 and stage 2. The measure is still to generate at least one report listing patients with a specific condition. Measure 12 is the patient reminders for preventive and follow-up care. This measure actually decreased from doing reminders for 20% of patients to 10%, but some of the other parameters changed specifically for preventive and follow-up care. So now for stage 2, the measure is that more than 10% of all unique patients who have had at least 2 office visits with EPs or sent a reminder for patient preference. So CMS has put a few more conditions on who you can count in this measure. For Measure 13, this is related to patient education and providing EHR identified educational resources to patients for more than 10% of the office visits that you have. This is the same measure as was in Stage 1. For Measure 14, medication reconciliation, this is also the same measure as you saw in Stage 1. You have to do medication reconciliation for more than 50% of your transitions of care when you transition a patient to care of another EP. So your EHR should be calculating these in the same way that it did for Stage 1. For Measure 16 is related to providing summary of care documents for referrals and transitions of care. So for Stage 2, this now is a three-part measure. The first part has to do with providing a summary of care record for more than 50% of your transitions of care and referrals. So this is Part A, where you'll fill in that data and how many patients you provided that summary of care for. And then that will take you to Part B, Part B refers to the fact that of those summaries that you do provide, 10% of them have to be sent electronically through your certified EHR technology or through an HIE. And so this is where we see in Stage 2 kind of more of an emphasis at CMS on health information exchange and electronic transmission. So in this case, it wouldn't, at least 10% of those summaries have to be sent electronically. And the third part of this is that at least one of those transitions, the summary of care record, has to be sent or exchanged to someone with a different EHR technology. So it's a three-part thing where you're, not only do you have to do the summary of care, provide the summary of care documents to a certain percentage of your patients, but then 10% of those have to be done in an electronic manner, and then at least one of those has to be done to another provider with a different EHR technology. CMS has also set up a web, basically a test EHR, so that, and there's a website for doing that. So they will, if you don't have another provider who you can send it to who has a different EHR, you can do the test with the CMS tool, the CMS test EHR. You can count that for this part of the measure. For 16 is the immunization public health measure. The change here is that it's moved from the menu set in Stage 1 to the core set in Stage 2. And now instead of just doing a test of electronic transmission of immunization data, you're now required to be in ongoing submission. There are expanded exclusions for this measure too. And then there's also several definitions of what constitutes ongoing submission. So you have the opportunity to choose from these options which one you're doing. You may actually be in ongoing submission with the immunization registry, but you can also pass this measure if you've registered your intent to do ongoing submission and you're just waiting validation from the state public health agency. The important thing here is to make sure that you register your intent to submit within 60 days of the start of your EHR reporting period. That takes us to the last core measure, which is to use secure electronic messaging to communicate with patients. So this is a new measure, and this, again, requires some patient engagement. This is a measure where more than 5% of the patients have to send a secure message to the provider using certified EHR technology messaging function. So in this case, again, it involves the patient communicating to the provider as opposed to the other way around. Once you've done that, you'll have completed your core measures, and then in the portal, you can go back and select on Start your menu measure attestation. Select the menu measures that you want to do. We'll just go through. We'll go through a few here. And the first menu measure, several of them are public health measures. So the first one is submitting electronic syndromic surveillance data to a public health agency. There's several exclusions that may apply to you in this case, and there's also several definitions of what would constitute ongoing submission of syndromic data. Again, the emphasis in stage 2 is that you need to pick menu measures that you can actually attest to before you pick exclusions. So you can't go through and just pick 3 and take exclusions if there's other measures that you can meet. The second menu measure is reporting electronic notes in the patient records. Some of these are similar from stage 1. So this is create electronic progress notes for at least or more than 30% of your patients. Menu measure 3 is making imaging results accessible through your EHR technology. And in this case, so if you have an EHR where you can actually access radiology, MRI, CAT scan type imagery, you could answer this measure, and it requires that more than 10% of all those tests that result in an image are accessible through your EHR technology. Menu 4 is reporting patient family health history of structured data, and in this case, it's having more than 20% of patients seen by the provider have structured data entry for at least one first-degree relative in terms of their patient, their family health history. I think that many providers do this as part of their regular practice anyway, and so this would be one that I think a lot of people would need. And the next one is reporting to cancer registry. Really similar to the syndromic and to the immunization registry public health measures. This may not apply to all providers, especially ones who don't regularly treat cancer patients. But in Texas, my understanding is that there is some required reporting to the cancer registry. So if you're doing that as part of your practice anyway, this is a measure that you could attest to. And then the last menu measure is electronic reporting to any other specialized registry, specialized disease registry in the state. So we've compiled a list of the registries in Texas. They're not that many other specialized registries, but if there are some that you do use as part of your practice and you report to, then you could attest to this measure. And with the same very similar exclusions and definitions of ongoing submission. All of these public health measures require ongoing submission in stage 2 as opposed to just a test, a single test as they do in stage 1. And actually I believe 5 out of the 6 menu measures are new. Stage 1, stage 2. The specialized registry here will ask you also to name the registry that you submit to and the type of specialized data that you submit. Type that in. So So that's kind of an overview of all the measures. Some of them have changed from stage 1 to stage 2. I won't get into the CQMs because there's too many of those, but you do have to attest to 9 of those out of 3 specific domains. With the CQMs, as opposed to the meaningful use measures, if you don't have any patients that fit or fall into that particular clinical quality measure, it's okay to have zeros in your numerator and denominator for some of those measures. But that's all I have, and I'm happy to take questions.
Thank you, Deb. Yes, we have some questions. The first one is on regards when you talk about keeping all documentation and screenshots. Someone is saying, we did all of those things, keeping records, etc., and yet in our most recent AIU audit, they are asking us for things that weren't asked for back when we attested for AIU. That's like a question.
They're asking about in a post-payment audit?
She doesn't specify, but I guess they're asking for more information that when they attested for AIU.
Okay. Yeah, we do. Well, it's good for me to point out that we do a pre-payment verification to the extent possible at the time of attestation. That's not considered an audit. It's really just an opportunity for staff to review some of the documentation that's being submitted. The post-payment audit is a formal audit process, and that's required by CMS. And in that case, the auditors are allowed to go back and ask for additional information and basically do kind of a deeper dive into the documentation. I like to compare it to something like an IRS audit, where when you file your taxes every year, you submit your tax returns with certain documentation. Usually IRS reviews that, and they send you your tax refund. But the IRS can always come back at a later date and want to look deeper into your records to validate and verify some of the things that you reported on your tax return. So that's kind of the analogy I use with this, where we do ask for some documentation on the front end. We don't ask necessarily for everything that we could ask for, and because we don't want to be too burdensome on the front end, and we do want to help providers get their payments, but we also are obligated to review those payments after they're made and verify some things that we may not have looked at during prepay.
Okay, the next question, it's about the core measure number 4, about vitals. Someone is asking, the blood pressure applies for dentists, but not the other 2. So what happens with that?
The question is that
it says, what about dentists? Blood pressure applies, but not the other 2.
Let's see. There we go. So in the exclusion, you can get an exclusion if this exclusion here, so for a dentist, if you don't believe that height and length and weight are not relevant to your scope of practice, you can be excluded from reporting that. So if you were a dentist, you could click yes to this exclusion, and then you wouldn't have to report on that for this measure. So your exclusions will cover all 3 of those things. If there's one of those that you don't think applies to your scope of practice, you can get an exclusion for that part of it.
Okay, the next question is, do we know if this is the same type of attestation format that will be on the Medicare site?
The measures are similar. I can't speak to the look and feel of the site, of the Medicare site. I'm sure their site is designed differently, but the measures are similar. We don't work in the Medicare program, so I'm not as familiar with all the specifics of the Medicare measures. but they're very similar, if not identical.
Okay, thank you. The next one. I'm not familiar with specialized registries for reporting diseases. Did you say that you have a list of them for Texas?
We've been gathering information on that. There'll be a drop-down list in the attestation portal that lists which ones we consider to be specialized registries. I believe we have, I don't know if Kristen can chime in. I don't have that offhand, but I know there were 3 or 4 that we talked about with our state health department. I can't remember the ones that we decided.
I'm not sure if you can hear me or not. Can you hear me?
Yes.
I can get those for you in a moment. I do have them, and they're in our database. I can pull them and send them to you.
Okay.
Okay, thank you.
There's not very many. I know one of them was like blood level, blood lead screening. Apparently there's a blood lead registry database in the state that people can report to, so that, I believe that was one that was in there. There were just a couple of things that the state health department suggested that we list because they thought that some providers might be reporting to those.
Okay, thank you. The next one. For the CPOE, 3 requirements, can you be excluded in one requirement but attestable for the other 2 between lab, radiology, CPOE? Well, that's what it says.
For the first measure?
For the CPOE, yes. Mm-hmm.
Yes, so there's an exclusion for each part.
Okay.
So so the first part has to do with just the medication. So if you write fewer than 100 medications during the reporting period, you could click yes for that exclusion, and that part of the measure wouldn't apply to you. And then when you go to the second part here, dealing with laboratory orders, if you write fewer than 100 laboratory orders during your reporting period, you could exclude yourself from this part of the measure, and the same for the radiology.
Okay, thank you very much. The next one. How will CQMs be submitted? When do you expect that to be ready on your site?
Right now we're not accepting CQMs electronically other than through the manual entry in the attestation portal. So just as it was for stage 1, you will come into the MI360 portal that I've been showing you here, and you'll fill in your numbers for your core menu measures, and then you'll also just manually type in your numbers for your CQMs right here in the same portal. So it looks a lot like these pages do, and you'll type in your numerator and denominator just like you do for the measures. That's the way right now for stage 2. That's the same as it was in stage 1. We are talking about working on a method to accept electronic submission of CQMs, but we're not at that stage yet.
Okay, thank you. The next one. Does a provider based on a rural health clinic qualify as an eligible professional, or does it have to be a freestanding clinic?
Yes, a provider working at an FQHC is definitely eligible. Any provider who's an eligible provider type, a physician, nurse practitioner, certified nurse midwife, PA in FQHC, a dentist, and now actually optometrist in Texas. If you're one of those eligible provider types and you meet all of the other program requirements, you are eligible for incentives. It doesn't matter if you work in a single provider practice or a group clinic or an FQHC. That doesn't matter. And we have many providers from FQHCs who have received incentives. I should mention, I did mention it, but point out that we recently had a state plan amendment approved by CMS that now allows optometrists, doctors of optometry, to receive incentives in Texas, as long as you meet all the other program requirements.
Okay, thank you. A lot of people is asking about the presentation slides. Are they going to be available?
Yes, we can make it available.
Okay, thank you.
I mean, I'll need to clean up my this document, my screenshots document a little bit, but we can certainly make the screenshots and my slides available.
Okay. Another question. What if we are not electronically linked to the hospital where we order radiology from? We do electronically order the radiology test, but it doesn't come back electronically. It's faxed to us and then attached. Will we have to just exclude that?
That is a good question. They're talking about for the CPOE measure?
Radiology, it says about the electronically ordered the radiology test.
Yeah, if the radiology orders are ordered through CPOE, that's what this measure is collecting. So if the orders are done electronically using computerized provider order entry, then that would count for this measure.
Okay. Well, those are all the questions that I see. If someone else wants to ask something else, I can get back to them by email.
Great.
Now we would like to give a mini advertisement. Carson Scott from West Texas Regional Extension Center, he's going to talk about the services we offer.
Thank you, Veronica. Yeah, this is Carson Scott. I'm the Director of Marketing and Outreach for the West Texas HITREC that you see here on your screen. We are one of 4 regional extension centers that are funded throughout the state of Texas. Some of the people on the call actually may be some of our clients. Like I said, we are funded by the ONC and also Texas Health and Human Services now for a specific program I'll mention a little bit in a minute. And we serve the 108 most western counties of Texas, so geographically half the state of Texas. And currently we serve a little over 1,000 providers and close to 60 hospitals, and that includes a lot of PCPs and then a lot of specialists as well. And the majority of our hospitals are critical access and rural hospitals. And on the screen here we have kind of generally our services listed out. It goes along with what Deb was speaking about with stage 2 and all that. We know there's a lot of providers out there that are still working on stage 1, and that's fine. At the Regional Extension Center for West Texas, we currently have 3 different programs that we offer. One is under the ONC program, and that is specific for primary care providers, and that includes pediatricians, internal med, OBGYN, and family practice. And so those providers that are still working towards stage 1 meaningful use, they can enroll with the Regional Extension Center and get our consulting at no charge due to our funding to do that. We also have a program that is specific to Medicaid physician specialists, and we are able to serve 200 of this group, and so that soon will be open to all specialists that actually serve at least 30% Medicaid, and that is funded as well. So there's no charge for those specialists to enroll with the Regional Extension Center. And then we have another option that's available to anybody out there, hospital, any type of organization, any specialist that is able to obtain our services for fee-for-service. And we make it a very flexible system. It's pretty low cost and those kind of things, and it's really flexible. You can even purchase hour by hour if you just want a little bit of assistance here and there. But ultimately, our goal is we are the trusted resource for this area. Our consultants are located regionally around West Texas. We know it's a large area, and so we have staff in pretty much all the urban areas and they also work those rural areas. So you really get to know the person that you're working with. It's the same person. We may pull from other people too because we have a lot of expertise on our staff, but generally you'll be able to work with the same person. And this is in-office assistance, so it's really geared for exactly what you all need. And you can see on the screen here we do a lot of meaningful use gap analysis. Helps a lot before and after someone attests. And typically we like to help someone before and then make sure everything's good so they can hopefully do well if there is an audit or something like that that comes up. But we can help practices that have already attested to meaningful use to make sure they've done what they needed to do. Incentive audit preparedness. There are a lot of audits going on. Roughly about 6% of our providers that are enrolled have been audited, and close to 30% of the hospitals that we have enrolled have been audited, pre or post-payment audits. And so they've done exceptionally well because we have helped them through the meaningful use gap analysis and things like that to do that. Medicare and Medicaid incentive payment registration attestation support. This is going through and making sure that you have everything done appropriately and help you get that payment. Privacy and security best practices, including tools and support to complete your security risk analysis. That's a huge one. There's a lot of providers out there that may not realize that they need to do a security risk analysis. Vendors do a piece of this. Their product has to be ONC certified, and there are some security measures in there that they will comply with, but there's also a big piece that each office or hospital must follow through with. It's generally a long questionnaire that must be completed. You find areas of risk within that and put policies and procedures in place and committees and things like that to show that you are doing your best to work through these. And so that has to be completed prior to your attestation, and if there's any major changes along the way. So we have ways to help you do that, and we have policy and procedure templates for those things as well. Stage 1 and 2. So going on with what Deb spoke about, we can help you guys get through those measures. And project management, workflow mapping, redesign, that's a big one too, especially for those who have not, well, even if you have adopted an EHR or if you haven't, really planning for that appropriately, knowing how things are going to change in your office, or if you're already using a record, maybe revisiting that, making sure you're using it to the best of your ability and that your staff are getting everything they can out of those records, and it's a smooth process in your office. Functional interoperability and health information exchange. As we all know, HIE is coming more and more prevalent in Texas, and so with Stage 2, this is going to be a much bigger deal. Helping you guys connect to those HIEs, knowing what's out there and what to expect. Vendor selection, implementation, and go-live support, if that is needed. We are vendor neutral, so we work with any vendor out there that is ONC certified or help you find one. And so we don't necessarily push any sort of record. We're just there to help you make a good choice. Patient-centered medical home, education, support, and ACO. These are some things that we are beginning to do now as well and help our providers and hospitals do this if this is something they're interested in to better their practice and hopefully get some additional incentives off that. And then ICD-10 transition support, obviously a big one, but we know this has recently been delayed, or the Senate and House approved that to delay that for a year. But the good thing is that gives you guys a little bit more time to prepare, and there's a lot of preparing to do on the office hospital side and also on the vendor side for sure. So we have some checklists and things we can help you guys with that, go through that process. So don't want to talk too much longer. You guys have heard a lot of good information today. We just wanted to jump on here real quick and let you know that we are here and available to help basically any and everyone. There's a lot of providers and hospitals that may be eligible at no charge. So if you want to give me a call, our main number on there is the 806-743-7960 on the slide, and just give that a call. You can ask for me, Carson Scott, and I can figure out what best fits your needs and those kind of things, or you can email us or check our webpage here, and we would be glad to help in any way that we can. And if anybody has any questions, I can answer those, Veronica. Thank you.
Okay, thank you. Thank you, Carson. I want to thank our speaker for taking time out of her busy day to share her knowledge with us. If you have any questions for today's presenter, please email Texas Rec using the email shown, and we will make sure you get an answer. Please join us next month for our next educational webinar in the series. We will be presenting PQRS, how the PQRS and EHR incentive programs interconnect through CQMs. It's going to be on May 7th. Hope to see you there. Thank you very much for attending today's webinar. Goodbye.